I am Kazem Rahimi from the University of Oxford, and I'll be talking about the BPL-TTC, which is a collaborative program of major blood pressure lowering treatment trials. The rationale for the study was to investigate the long-standing controversy around the effects of blood pressure lowering when blood pressure is not very high, and also to look at whether the effects differ among people who have a pre-existing cardiovascular disease and people who don't. So this was a large-scale individual patient data meta-analysis, the largest of its kind ever conducted to date. So we pooled data from about 50 large-scale randomized clinical trials. That led to a database of about 350,000 randomized patients. And by having such a large database, we were able to stratify the patient population into different groups. So in the first stage, we stratified individuals into the two groups of people who have had a pre-existing cardiovascular disease, that is a secondary prevention setting. And the other group was people who did not have a pre-existing cardiovascular disease, that is stroke and ischemic heart disease. And that was the primary prevention setting. And further on, each of those groups were further stratified into 7 categories based on the systolic blood pressure that individuals had prior to randomizations. And the groups went all the way up from greater than 170 millimeter mercury systolic to less than 120 millimeter mercury systolic. And by having such a large data set of about 350,000 patients, we were still able to have a large fraction of individuals falling into the categories of baseline blood pressure being less than 130 millimeter mercury. And in a sense, we compared the proportional risk reductions in effect of blood pressure lowering on cardiovascular events, that is incident heart failure or hospitalization for heart failure, death, stroke, and myocardial infarction. So in these large-scale randomized clinical trials, all in the inclusion criteria varied. Some of them included people without pre-existing disease. Some of them included people with disease. Some investigated an intensive strategy versus a less intense strategy of blood pressure lowering, and some were placebo-controlled trial. And the third category of trials were those that, in a sense, compared 2 classes of drugs against each other. And we included all of them, and to make sure that we can still compare the findings across those studies, we standardized the intensity of blood pressure lowering in each of those trials for a 5 millimeter mercury systolic blood pressure reduction. So what we found was that the proportional effects did not differ according to presence or absence of prior cardiovascular disease. On average, the risk of major cardiovascular disease was reduced by about 10%, irrespective of the disease status. And the same applied to an analysis stratified by systolic blood pressure. There was no evidence that the proportional risk reductions varied across the different categories that we investigated. So that implies, in a sense, that neither pre-existing disease nor blood pressure itself had a key role in terms of determining or modifying the treatment effects. So the conclusions are, the effect of blood pressure lowering is proportional to the intensity of blood pressure lowering achieved. And that there was no evidence that those effects are modified by pre-existing cardiovascular disease or baseline blood pressure. And that in turn means that we should probably consider antihypertensive medications as treatments that modify cardiovascular risk, irrespective of blood pressure and prior disease. So in a sense, this opens up a whole group of individuals who have not been considered for treatment to be considered for treatment. So the impact on clinical practice is that the emphasis on blood pressure itself, on selection of individuals who might benefit from antihypertensive medication does not seem to be justified. And we should not really be making a distinction among people who have had a cardiovascular disease or didn't when it comes to selecting people for treatment. That doesn't mean that everyone should be treated, and that is where the clinical decision making comes in. We need to consider absolute risk and potential harms of the treatments, but certainly prior disease and blood pressure should not be a reason for withholding treatment from these individuals. So the next steps are, the key questions remaining are still the potential side effects of the treatments, the effect of the treatment on outcomes that have not been previously investigated in detail, outcomes such as valvular heart disease, atrial fibrillation, dementia, diabetes, to look at the wider impact of the antihypertensive medications across the population.